Hello everybody, welcome back to Nbme 26, the concepts I think you need to know by the time you finish this exam. As always, like and subscribe if you like this content. The next topic that you need to know by the time you finish this Nbme is going to involve the placenta. Now what I encourage you to consider right now is what's it called when the placenta won't let go. You have the bleeding after delivery. Placenta accreta, it's the abnormal attachment to the myometrium. Let's do a practice question to drive this home. So we have a 37-year-old female, Gravata 4 Para 3, C-section at 36 weeks due to a suspected placenta previa. She has postpartum hemorrhage and attempts to remove it is unsuccessful. The uterus shows chronic villi embedded directly in the myometrium. What's the diagnosis? Placenta accreta. So how do we know? Well, a couple of things. Risk factors. C-section, difficult placenta separation, huge. Also massive bleeding. So the accreta will lack this decidual interface. The decidual cast is the shedding of the entire uterine lining as a cohesive mass. It's when your uterine lining sheds into one large piece as opposed to drips and drops like the menstrual period. Painful but rare. It's not going to be placental abruption. And the reason why is abruption is going to be before delivery. Uterine anatomy is going to be your boggy uterus. Retains the centroid lobe. Accessory placenta left behind causing the bleeding. Uterine rupture. Loss of the fetal station. Now placenta accreta is one of the leading causes of emergency peripartum hysterectomies. So you have a defective decidual layer, and so the placenta anchors directly into the myometrium. That's what's going on here. So the most important thing is prior surgery makes you think of placenta previa, which gives you a high risk for the accreta. Histology, villi straight into the myometrium. The buzzwords, the villi and myometrium. You should definitely think of this condition if the placenta is unremovable, right? No separation. So if they've had multiple kids, like 3, maternal age is greater than 35, then they might have uterine wall remodeling issues, which can lead to this problem. So really just be on the lookout for the villi in the myometrium. Absent decidua, huge giveaway. Prior C-section, previa advanced age, the placenta won't come out. Here's one more practice question to illustrate this point. 33, G4P3 woman, 2 prior cesarean deliveries. The placenta fails to separate, chronic villi extending into the myometrium, absence of decidual interface. What's the diagnosis? Placenta accreta. Uterine anatomy is to the boggy uterus that we talked about. Doesn't contract, but it's not invasive placental. Abruption is before delivery. Abruption before delivery. So yeah, it's a placenta that refuses to detach and it bleeds out, won't let go. Obstetric emergency. It's linked to pre-cesarean scars and placenta previa. Last concept before we move on, placenta previa. It's when the placenta blocks the exit. Painless, previa, painless. So it's going to be painless 3rd trimester bleeding. The placenta implantation is over or near the cervical os. So sudden painless bleeding, 3rd trimester, placenta previa. Abruptio placenta, that's going to be super painful. And this can be partial, it can be complete, covering, or marginal. And you don't do a digital exam because you have a risk of triggering your hemorrhaging. So similarly, also we said like 3 kids greater than 35. Well, for this one, we have prior C-sections are also a risk factor for placenta previa, and previa is a risk factor for accreta. So more pregnancies, more chance for previa, advanced maternal age, and also smoking is another risk factor. So here's a practice question for that. 29, G3P2, 31 weeks gestation. What's the diagnosis? Well, bright vaginal bleeding, and it's covering the os, it's previa. Abruptia, that'd be painful bleeding with a rigid uterus. Vasoprevia, that's a fetal vessel rupture. So the fetus would be in great danger. Uterine rupture, sudden severe pain. Cervical insufficiency, painless dilation of the cervix without bleeding. Here's a quick question on vasoprevia. So the big thing is the fetal heart is showing 80 beats per minute, but the patient is stable. So it's a fetal problem. So vasoprevia. In placenta previa, fetal heart is normal. It is painless bleeding though, so that makes you think of it. Abruptio, painful. Uterine rupture, painful. Cervical laceration, bleeding after delivery, but definitely not fetal bradycardia. So in vasoprevia, which is our last topic we're covering here for the placenta stuff, vasoprevia, the fetus can exsanguinate, so like lose all of their blood, in less than 10 minutes. Less than 10 minutes and boom, you're out of blood. It's when you have unprotected fetal vessels that cross over the cervical os. So the only solution here is just going to be a cervical C-section. Pregnancy is dangerous, folks. Everybody go thank your mom. All right, next topic, super high yield, important. We're going to be talking about measles. So measles virus infects the respiratory system, so your epithelium specifically, and it spreads through the lymph. So if your kid's healthy, they have a robust immune response and they get rash and clearance. But if you're immunocompromised, then the virus will spread to the lungs. So immunocompromised, it'll spread to the lungs. So let's do a practice question here. 2-year-old boy has congenital HIV. He's got cough and respiratory distress. 3 weeks earlier, in contact with a child, high fever and a rash. The boy never developed the rash though. Bronchiolar lavage has multinucleated giant cells. What's responsible for it? It's going to be the measles. It's giant cell pneumonia. Immunocompromised, like those with HIV, the rash is absent due to that no T cell response. Okay, why isn't it RSV? So RSV is wheezing and bronchiolitis, no giant cells, especially not immunocompromised stuff. So CMV, classically your ally inclusions, there's not going to be multinucleated syncytia. This is going to be common in AIDS, but it's a different pathology. Not rubella. Why? Because no giant. Why not influenza? Well, that can cause viral pneumonia, but again, no giant cells, no syncytia formation. So you really got to be careful with measles with no rash because they could be immunocompromised, and that's the reason they don't have the rash, because they're not healthy. Because measles virus uses the F protein to cause cell fusion, so you get multinucleated giant cells in the lungs. If you're immunocompromised kids, you have no rash, uncontrolled replication, you get the giant cell pneumonia. And this is really bad. It'll destroy your lung parenchyma. Another practice question. Boy with HIV has hypoxia, respiratory distress after exposed to a child with fever and rash. This dude has measles, but he never develops it, so he's got the measles. Why? Because he's immunocompromised. Rubella would cause a rash, and influenza causes pneumonia, but not giant cell. Rubella is a descending rash. Toga virus, cataract sepsis, PDA, blueberry muffin. Let's do a rubella question real quick. 6-year-old, low-grade fever, pink rash, straight on face going downwards. Definitely rubella. So measles has those Koplik spots. The rash is darker as well. Para, slap cheek, not descending. Human herpes 6. So this is roseola. And what I want you to think for roseola is rosy first, because you have that rash and then the fever for roseola. Here, measles, we don't even get the rash and the immunocompromised, because it can't mount the response and the F cell just goes havoc on the lungs. RSV, no giant cells, CMV, ally, rubella, that's what we're doing now. It's like descending. Influenza, no giant cells. Roseola, rosy, and then fever. And then Epstein's-Barr causes pharyngitis, fever, fatigue with post-cervical LAD, not the descending rash. This is the part of the video where I do a brief aside to the many stupid Americans who don't believe in vaccinations. That's why I have my American flag in the background. So we see measles where immunity breaks. So you get measles outbreaks because of unvaccinated populations in the good old US of A, because they are too good for medicine. So measles is going to be a highly contagious paramyxovirus through airborne transmission. So you get an unvaccinated child whose only sin is having stupid parents, presenting with your fever, cough, coryza, conjunctivitis, and rash. So classic measles. They refuse to get the MMR vaccine, probably due to their mistrust in science, also misinformation, false claims about autism, for instance. Maybe they believe what RFK Jr. is saying out there. Who knows? Honestly, there are a lot of problems with the scientific community at large, not to justify at all vaccine refusal and distrust, but anyways, for whatever reason, they deny this vaccine, which has done wonders. They got some global travel, some vitamin A deficiency. That'll worsen your measles severity, especially if they are malnourished. And then they might get complications like giant cell pneumonia if they're immunocompromised. So they inhale it. It spreads via the virus, infecting the skin, conjunctiva, immune system. You get a cytotoxic T response that causes the rash and the clearance. If you have lack of immunity, then it just keeps on going. The prodrome is the cough, coryza, conjunctivitis, and the Koplik spots. And the vaccine is 97% effective with 2 doses. And it does not cause autism. Community with declining vaccination reports a cluster of children with fever, running nose, red eyes, and spreading rash. What's most likely cause? Measles. Why? Declining vaccinations. Also, you have those prodromal symptoms, rash. Influenza has no rash. Rubella does not have giant cells, so no giant cells there. Parvovirus, that's the slap cheeks, not widespread outbreak with pneumonia. Adeno's not measles-like, it's the most common pharyngoconjunctival fever. So yeah, measles was like eliminated, and then it made a comeback because vaccination rates, misinformation, and so the fix would just be 2 doses of MMR. Spread by ignorance. It is spread by ignorance. I like that. It's terribly sad, but it's true. Okay, all right. Get off my soapbox here and go on to the next question. All right, so in this question, we have a 35-year-old man. He's got urinary incontinence after a motor collision with a pelvic fracture. He's got a distended bladder and urinates only small amounts. He denies urinary urgency or awareness of bladder fullness. Which nerve is damaged? Okay, this is a very interesting question here. So the answer is going to be our pelvic, but why is not the pudendal? Well, potential, I want you to think of voluntary control, not overflow. So what we're going to do is we're going to draw a little bit of a bladder here. And when you think of the detrusor muscle, we think of this thing on the outside here, detrusor. And the answer we said is pelvic. And the reason why is because our pelvic nerve has parasympathetic input. And so it's going to target right here on these M3 receptors. And so your parasympathetics typically help with urine voiding. Like some autonomic drugs will act on the smooth muscle to treat bladder dysfunction on these M3 receptors, right? Because that's where the pelvic nerve is going to innervate. Now the hypogastric, which is C, that's going to be a sympathetic. Now these guys have receptors as well. So like on the alpha 1 and the beta 3. So with the hypogastric, the deal is loss would be a loss of your sympathetic tone. And so it'd be uninhibited voiding, not retention. So it doesn't make sense that it's hypogastric because that's a sympathetic. So this is our parasympathetic. It starts with a P. Prudental is voluntary, so maybe not that one because this is involuntary. And just to kind of like flush this out here, these guys right here, this is like our internal sphincter, internal urethral sphincter. And then down below here, you have these other muscles. You have the external urethral sphincter right here, external urethral sphincter. And so when we talk about the prudental, when we say, hey, that's voluntary, that's because it's right here. These guys have nicotinic receptors. And so the prudental can voluntarily control these. That's somatic output there. So sympathetic is going to help with retention and parasympathetic is going to help with your voiding. So hopefully that kind of explains this question where we have a dude who's got urinary incontinence. He can't urinate, right? So that means these guys are too strong or these guys are too weak. And it's not voluntary control, so it's not the prudental. So boom, boom. And then ilioinguinal and genitofemoral, those guys are like the groin and the sacral region. And that's like sensation stuff and not bladder. So just cross those off immediately. And then the only thing we're left with is pelvic, and that's parasympathetic. So that's inhibited. You're not going to be able to void. And that's what our guy's problem is. So yeah, hypogastric helps store the urine. So you're going to be leaking there. You'd have a total lack of control. All right, so pelvic, S2 to S4, parasympathetic, and the prudental, S2 to S4. But they do the external control through the external urethral sphincter. So that's that. Hopefully that was a helpful thing. We definitely need to know this for our first Nbme. For our next question, anytime you see a musty odor, fair skin, seizures, and developmental delay, it's going to be PKU. So it's a homozygous point mutation on the intron, and that causes RNA splicing problems. So that's PKU for you. Exon skipping. It's a defect in the phenylalanine hydroxylase or BH4 cofactor, so you have high phenylalanine, low tyrosine. Low tyrosine causing this fair skin. RNA splice site mutations in the introns. You get those symptoms. Okay, so it's a splice site error. Here's a practice question. Developmental delay, hypotonia, seizures, pale, musty body odor. What describes the mutation? RNA. It's not nonsense. That'd be a premature stop codon. So it's like stop the nonsense. Trinucleotide repeat expansion. Huntington's Fragile X, not PKU. Frame shift caused by indels where you get like some insertions, not splicing. Epigenetic slicing, DNA methylation histone modifications. That's not right. Yes, it's just one letter. It's literally just a G to an A mutation in the intron can derail the entire splicing process, and that's what we see with PKU. Okay, so that's a little bit of genetics and PKU for you. We'll just do 5 more topics. Now for this one, we have to know how doxy works. Doxycycline. So it treats Lyme disease, but how? How does it treat Lyme disease? Well, it inhibits the aminoacyl tRNA binding on the 30S. In your face. In your face, that's what it does. 30S, you can't see, you can't see. All right, so Lyme disease. What makes you think of Lyme disease? Well, travel, if we're going to Cape Cod, going to the Northeast, Borrelia, Bergdorf Ferry territory, makes you think of Lyme, give them doxycycline. Now, there's a classic tetracycline adverse effect, that's the yellow teeth in the fetus. So you're inhibiting that tRNA attachment. That's tetracycline's mechanism. So Borrelia Burgdorferi is going to be a spirochete that's transmitted by the Ixodes tick. So Ixodes, think of this in your head. Ixodes, Cape Cod, treat with treat with your tetracyclines that block that 30S ribosomal subunit to block the tRNA binding site at A. So how this works, Lyme disease, is you get the Ixodes tick, you get bit, and the Borrelia is going to invade the skin. So you get that skin invasion, and it causes a rash. Doxycycline enters the cell, and it binds to that 30S subunit of the ribosome, preventing the tRNA from accessing that A site. So the A site is now clear. It'll halt protein synthesis, and then you're good to go. So here's our practice question about this. 28 woman, large red rash. She had a camping trip at Massachusetts, Lyme disease, and she wants to know about the fetal bone and dental toxicity. What's the mechanism? It's going to be inhibition of aminoacyl tRNA binding. And so it's going to be C. Inhibition of DNA gyrase, that's fluoroquinolones, not euthyroid, that's a tendon rupture. I've definitely seen a question on that in previous Nbmes. So definitely take that into account. Fluoroquinolones, gyrase, tendon problems. Inhibition of aminocycling, that's the answer. Inhibition of peptidoglycan cross-linking. Beta-lactams. That's how penicillins work. Penicillin, cephalosporin. Dihydropteroate synthetase. It's going to be sulfonamide, so it targets your folate synthesis. And RNA polymerase, think rifampin. Rifampin, rifle RNA. We think of the RNA for rifampin. Those are treatments for TB, not for Lyme. So it's not going to be your RNA polymerase. That's definitely R for rifampin. Beta-lactamase, penicillin, that's how they work. Beta-lactams, peptidoglycan cross-linking. All right, and that's that. Going on to our next little question here. Now, this is just a kind of rudimentary question here, but imagine we're looking down at somebody. There's the ears. So this is like a fetal skull that we're looking at here. And we kind of have these suture lines. So that's going to be the frontal suture. There's our lambda. Or we say hi lambda. And that back there, of course, is going to be our lambdoid suture here. And then this guy right here, that's the sagittal. And then this one is a coronal. Coronal because you wear it like a crown. So if you get premature closure of the sagittal suture, scaphocephaly, boat-shaped skull. Here's our practice question. This guy's got a narrow skull. Imaging shows which term? It's going to be scaphocephaly. You don't really need to know the name here, but you do need to know the suture that runs posteriorly between the two parietal. It's going to be that sagittal suture fusion. So it fuses and then you can't grow. It's a midline fusion, so it prevents it from growing wide. It's the sagittal. So this guy's like, imagine you sutured this closed, then it would grow this way, kind of look like Larry the cucumber, as opposed to Bob the tomato. Okay, so just a little bit of info on that. All right, so this is super high yield, so let's talk about ACEs real quick. ACE inhibitors like lisinopril, what happens to angiotensin 1? They're going to increase. How about angiotensin 2? It decreases because it inhibits this step. And what about bradykinin? It's going to go up. And that's going to cause two things. What? Cough, angioedema. That's what it causes. Angiotensin 2 decreasing, that means what? Less vasoconstriction. Less vasoconstriction means less aldosterone. So these ACE inhibitors, they inhibit this ACE here. And ACE has two jobs. One is to convert 1 to 2. The next one is to break down bradykinin. So you can't break bradykinin. And what is bradykinin? That's a potent vasodilator. If you can't break it down, you're going to get dilation. And so that vasodilation from the bradykinin is actually part of the reason why we lower the blood pressure. But you get the dry cough because of the bronchial irritation by bradykinin. Also, you get some bradykinin angioedema. So that's the swelling, and that can be life-threatening. So yeah, just watch out for that. Think of the ACE inhibitors as blocking the vasoconstrictor and preserving the vasodilator. That's why they work so well. Of course, my custom interface is telling you guys to like and subscribe. Can't control it. But if you do like and subscribe, then this will change. So literally you clicking the subscribe button goes bing, and it changes my wall here. And it goes, this person subscribed, and that's great. So if you want to make my day, hit that button. By the way, fit of the day, let them theory. You guys just do your thing, you know? Just do you. Doesn't matter whatever anybody else thinks, you know? Let them do whatever they want to think. Wow, that was so poorly stated. But who cares? You do you and let the consequences follow. You know? Love that theory. Love that idea. Okay, we'll call this the last question right here. I want to explain the topic of CRP. So CRP binds phosphocholine on dead cells in bacteria. It's an opsin that facilitates phagocytosis. This, I want you to think of as an acute phase reactant. And anytime you see acute phase reactant, think IL-6. Hot T-bone steak, it's the K. K for acute phase reactant. So yeah, opsonization, the CRP binds, enhances the recognition through those Fc gamma receptors. A good way of thinking about this is it fixes the complement. So these guys are just trying to help out. They're just trying to do their job with the acute phase reactant stuff. It's a non-specific marker to track inflammation. So let's say that a person's got some lupus going on and they got some increased C-reactive peptide. They might ask like, hey, where's this coming from? And you'd have to know that this is synthesized in the liver. Let's do a practice question. 48-year-old man, fever, malaise, productive cough, x-ray shows right lower lobe, consolidation, and leukocytosis and elevated C-reactive protein. What describes the immunological role? It's going to act as an opsin and promote the phagocytosis. Enhance the cytotoxic T cell activity? It's innate. CRP is innate, so no. That'd be an adaptive. Induces chemotaxis directly? No. That's the job of IL-8. 8 is much older and more mature, so he can do taxis. He's not like the hot T-bone steak. He's more mature. He can do taxis. Chemotaxis. Get it? Does it inhibit complement activation? No, it actually promotes complement. Does it degrade extracellular bacterial toxins? Nope, it doesn't. This is just a C-reactive protein. It's just an acute phase reactant guy. He's just a cute guy. Now, C-reactive proteins can surge over like 1,000-fold if you have acute inflammation. What is it doing? It's binding those dead cells and also the invaders. So it goes in and it's like, I'm going to bind you. I'm going to bind you. You're going to die. You're going to die. You're going to die. Goes in there's like, I'm tagging you guys as bad. So it's promoting phagocytosis through its opsonization, especially and complement activation through the C1q. So there you go. That's CRP synthesized by the liver. And these have been some more concepts that you need to know by the time you finish your first Nbme. I'm going to make this into a playlist, so definitely be sure to like and subscribe if you want to see the rest of these videos. And guys, everything you're seeing in this video is extremely high yield, like super, super high yield for step 1. It was amazing. I actually got some really encouraging text messages from a couple of students who purchased the software. They're like, thank you so much. It was so helpful, all the stuff for test day. And that's my goal, folks. I just want to help you guys succeed. And so this is everything that I think is super important by the time you finish Nbme 26. These are the things that I think you should know. If you like the series, please like and subscribe. I'll make some more videos. Maybe I'll do by the time you finish 27, by the time you finish 28. Again, this is not affiliated with Nbme. Highly recommend that you go and purchase those exams. This is my content. This is completely separate. But this is definitely going to be beneficial as you prepare for the Nbme exam. And this is us. That's actually just a cell. And if you keep zooming out, that's my thumb. And it's telling you to like. I don't know. All right. Anyways. Thank you guys so much for watching. We'll see you in the next one. Oh, and take care of yourself out there. Life is hard enough. Make people smile. Do what you love. And let them. Let people show who they are. People who make the time and the effort, they matter. They're going to be important for your life. And remember, if somebody does you wrong, there are like 8 billion people on this planet. As Matthew McConaughey once said, you got to thank them for saying, I'm glad I don't have to waste any more time on you, and I can spend more time with the other 7,999,999,999 people who might treat me better than you did. So yeah, have a great day. Go outside, touch some grass. We'll see you in the next one.